what do we do in healthcare when we want family docs or emerge docs or whatever to change how they take care of a certain clinical problem? We just put the information out there and we expect them to somehow incorporate that into their work routines, on the fly, without any cognitive support, without any kind of, socio-technical system support for doing so. Well, I'm sorry, but just do it as a shoe commercial. It's not a prescription for healthcare change.
That's Dr. Lee Green, and this is The Dip.
Wang Yip.
Sean Kanungo.
Now, what episode of The Dip is this?
I believe this is episode number 9, although I don't know if we count our bonus episode.
No, the bonus episode does not count in terms of the total episodes.
Okay.
So this is exciting. We've got 2 more episodes left of The Dip. Can you explain to the audience what The Dip is? Because I'm sure there's lots of people who are tuning into this episode for the first time.
Absolutely. Well, The Dip is the brainchild of Sean Kanungo.
No, it's not. But...
What every episode explores is the disruption that's happening in every industry, in a single industry. For instance, we've looked at publishing, we've looked at 3D printing, we've looked at the sharing economy, and every episode we look at 3 things: disruption that's happening, innovation that's happening in that industry, and a prediction from both ourselves and our guest on what's to come in the future.
Now, I'm really curious because I know you're not totally into the news and you're not, you don't follow everything that's happening around the world. What is keeping you occupied these days in terms of content, in terms of experiences? Maybe there is a news story that has caught your attention. Wang Yip.
News, not really.
I found an article about...
I don't know. That was so
Siri.
Weird. Sorry about that.
Siri was trying to jump into the podcast.
Right.
Well, no, I don't follow a lot of news. I think what's keeping me busy these days is I'm trying to just consume a lot of content, but I'm very conscious of what I'm consuming, because in previous years, I like to read a lot. I like to crush a lot of podcasts, audiobooks, but I haven't really produced anything.
Now, is this like a New Year's resolution or something like that?
It's not really a resolution, but it's more of a goal or a theme that I have. A resolution, I feel, is either you are successful or you fail your resolution. This is more of something that I want to try to do more of. I don't have a success criteria. I just want to do more of it.
Okay, so what is it? What I want
to do is I want to consume less. I want to be more conscious of what I consume, but also I want to produce more things.
Right.
And so what I've been doing lately is, one of my goals this year, I had this goal in previous years, is to read at least 1 book a week.
Yeah.
To read about 50 books in the year. But after reading, I jot down some notes.
Okay, I got it. Yeah.
And trying to figure out, what did I take away from this book? How can I use it to apply it to my life?
And Wang Yip, what are you reading right now, or what have you already completed in 2016?
Well, I've completed a couple of books. I completed 4 or 5 books so far. I read Elon Musk's biography, which was... That's
with Ashley Vance?
Yes, that was amazing.
You know what? I found that at the end of the book, in the middle of the book, it gets really technical.
Mm-hmm.
Like they talk about space and like the technical aspect. I just want to learn about the man, the myth, the legend. Like I wasn't too interested in the technical aspects of space, automotive. Like I thought I got a little bit too technical.
I didn't feel that way, I think, reading the book. Just the way that you put it, though, I would have liked to hear more about the things
stories,
that he does.
The stories.
The routines
exactly.
stuff that he does. Yeah, absolutely.
I don't care about the rocket going up and crashing. Like, I want to know how he felt during that time. Mm. But I think it was a good book, well recommended.
Mm-hmm.
So that's one. The other book?
I read another book. It's by someone named David Pogue. I think I'm pronouncing his name right. It's Pogue. And he basically has what are called life hacks. Do you know what those are?
Well, life hacks are ways to increase productivity, increase your time.
Little tips in general that people may not have heard of, may not know of, and that, again, help save you time, money. One tip that I got, which was really cool, I fly to Vancouver a lot because I'm from Vancouver.
Yeah. Baller.
And every time I fly to Vancouver, one of my parents comes to pick me up. But the way that YVR is designed in terms of the arrivals and people picking up other people from other flights, it's not well designed at all. There's a lot of cars that just wait around because sometimes flights are delayed. There's a lot of traffic jams that happen right at that specific section. And so one of the tips that I got from this book was, instead of going to the arrivals area when you arrive, like everybody else does, go to the departure level.
Right.
And if you go to the departure level, people drop off others to get their flights. They leave right away. There's no traffic jam.
Now, what you're doing is dangerous, Wang.
What?
You are recommending to our audience to go up to departure so they can be picked up. Now,
Yes.
if there was an influx of people that actually did that, then the departure gate would also be jammed with people who are getting picked up when they should be getting dropped off. So you're causing a very dangerous
Could be.
situation.
I don't think everyone will do it, though. I don't think enough people will do it that will be a problem.
Right.
And if you think about it, if it's more efficient at the departure gate to pick up arrivals, the arrivals will also...
Well,
be
it's
more
only efficient because you are the only one doing it.
Yeah.
It's not more. It's the same thing at the arrivals or departures.
But
the
if people from the arrivals listening to this podcast go up to the departures, that's less people at the arrivals.
you know what? There should be a premium pricing placed on this whole arrivals thing. Meaning there should be different floors. There should be like 10 floors, and based on how much you pay, you could pay $40 and you ascend to the top parking spot or the drop off point, and then there'll be less and less people that will go to that point.
But it's free. You can't put a price on that, I don't think.
Great life hack,
Yeah.
Wang Yip.
I don't know.
Great life hack.
I'm
Wang
going
Yip.
to try it. I haven't tried it yet. And then I read another book. It's called 1 Second Ahead, and it's about mindfulness, which is, I
Wonderful.
think, a topic that you and I are both interested in. And meditation in general is something that I've heard lots of successful
And do you
performers-
meditate?
I don't meditate, no. But I think meditation and mindfulness, although similar, aren't exactly the same thing.
Okay.
Because
mean?
you can be mindful. You can just take 10 seconds. It's not really a meditation. Or maybe it is. I'm not sure. But I think it's just about being present in the moment.
Right.
And meditation does help you do that, but I don't think you... Like for me, I think the big barrier is, do I need to take a few minutes out of my day? And it just seems weird because I have meetings all the time, or
Right.
sometimes I'm just talking with
So-
a client and it just can't go, and I got to step out of the room. I got to meditate. It's just weird. That was a big barrier to entry for me in terms of meditation, but
Yeah,
being mindful, at least you can take a couple seconds to
I started
focus.
I started meditating probably about 3-4 months ago.
What kind of meditation do you do?
I do the Russell Simmons meditation. Do you know who Russell Simmons is?
Yes.
He was the CEO of Def Jam.
Okay.
And
What is
I
the
don't know
Russell
if you-
Simmons meditation?
So he has an app on, I believe it's on Android and iOS.
Okay.
It's actually called Meditation Made Simple.
Meditation
and-
made simple.
Yeah, and then so he has
Are you ready
see?
to meditate?
Okay.
Close your eyes.
It's Russell
Take
Simmons.
a deep breath in.
Anyway, so he has 10 to 20 minute
Are you doing a headstand?
practice.
There's a headstand
I'm
in
not
the
doing.
app here.
I'm not doing that.
Headstand
Russell
wide.
Simmons is doing the app.
Okay.
Doing it. It's a simple app that Russell Simmons has made to help you meditate. And actually, as weird as it sounds, I'm actually following Russell Simmons's meditation app, and he's helping me meditate 10 to 20 minutes at a time. So I'll wake up in the morning, I'll do a 10-minute meditation
Yeah.
session, I'll go about my day.
Okay.
And it actually, like, I think a lot of people want to they think that something's going to happen, like a miracle is going to happen, like right after they meditate. It doesn't happen. Like there's not, like I don't feel any different right afterwards. But oddly enough, like during the day, I'll have a level of clarity or a level of focus when I'm like speaking with people or I'm working on something. I've noticed it, and I don't know if it's like a I don't know if it's the meditation or maybe it's a placebo effect.
Mm-hmm.
I actually am less like frazzled, I would say. So I don't know if it's attributed to meditation or I'm just thinking, oh, I meditated, so I probably should be more clear or focused. Whatever it is actually working.
I've known you for a while. I don't think you get frazzled, though.
No,
Do you get frazzled?
No, I'm always thinking about like a billion things in my head.
Really?
Oh, I'm always just, my mind is running.
Now that you've done meditation, has that stopped? Or have you now
No, I'm still
noticed that you're focusing more on one thing in particular?
I think it's helping me focus at one thing at a time. I think it's helping me do that better. For example, I was talking to somebody. I remember I had a really good meditation session. I was talking to somebody and I was thinking to my head, I'm like, wow, like I am so in the zone with what they're saying right now. Like it's like I had laser focus on what they were saying. Even though I was thinking about that in my head, I was thinking I'm so laser focused. And it was an odd sensation. So I think I'm going to continue at it because I see the benefits of it. I want to get the Muse. Do you know what the Muse is? It's like a meditation headband.
Oh yes.
So what it is, it measures your
I thought it was for sleeping. No, it's not for meditation.
I believe it's for meditation.
Is it? Oh,
yes.
Okay.
Yes. And so I want to get that so I can measure my level of meditation. Anyway, so that's my meditation. Russell Simmons, as odd as it sounds, is helping me meditate.
Very cool.
There you go. So Wang, what is the disruption that we're going to be exploring today? I'm excited to hear about it. What is it?
Today we're going to be talking about healthcare. And healthcare, I think, is one of the industries that I am particularly interested in because there's so much happening in healthcare.
I thought there was not much happening in healthcare.
No.
Healthcare is one industry that should be disrupted, but lacks innovation.
I would argue that there's a lot of disruption, there's a lot of innovation happening in healthcare, but there's a lot of different barriers and challenges to the disruption and innovation being ubiquitous in healthcare. I mean,
ubiquitous meaning across regions or across hospitals or?
Yeah.
Okay.
Everything, really. Across hospitals, across regions, across countries. Let me just give you an overview of all the different topics that we talked about. And
who did you talk to?
For this interview, I talked to Dr. Lee Green.
Yeah, my name's Lee Green. I'm professor and chair of the Department of Family Medicine here at the University of Alberta and professor emeritus on active status at the University of Michigan as well. I'm a practicing family physician and I teach medical students and so forth, but really what I do is I'm a health services researcher with special interest in primary care policy and primary care practice transformation. In particular, my own research is applying cognitive and organizational science tools to studying and facilitating transformation of primary care practice.
Super, super smart guy.
How do you know Lee Green?
I reached out to the Faculty of Medicine and I asked them, hey, I run this little podcast called The Dip. I want to talk to someone about the disruption that's happening in healthcare. And they pointed me in Dr. Green's direction.
And you went there?
Yes.
Now you were meeting with a doctor. So did you have a tie on or did you have a suit?
I went early in the morning. So I was wearing a suit and I was going to work afterwards.
Did you research the topic beforehand? Did you?
I just went in cold turkey. No, I researched the topic. I researched the topic. I gave him a list of questions so that he's also prepared. And we talked about, again, a number of different topics that I think would be quite interesting to our audience. We talked about wearable technology. I see you're wearing something.
It's a jawbone. Yeah.
Yes. So we got into that. We talked about the disruption that's happening in surgery. Talked about robots assisting surgery, 3D printing in surgery. We talked about electronic health records, a huge topic. And at least from my perspective, I don't see it being ubiquitous. I still go to the clinics. I still have physical records. Why aren't electronic health records everywhere in Canada?
Right.
Talked about diagnostic technology. There's a company called Theranos. They conduct lab tests with just a few drops of blood.
Right.
We talked about smart contact lenses for monitoring diabetes patients. We talked about Walmart buying low-cost healthcare. Again, a number of different topics we can dive into any of those topics
Well,
and more.
let me tell you about this. I don't know much about healthcare, similar to many of the
You
different
did
topics.
research afterward. You did research beforehand, right?
Well,
For this podcast.
I always do research before we
Okay,
talk.
excellent.
Wang.
Excellent.
But no, I'm not a healthcare guy, and I think a lot of people who are listening to this, they're not healthcare. They don't play in the healthcare space.
Sure.
However, here are my thoughts before we get into Dr. Green.
Okay.
Sean Kanungo. Let Sean.
Dr. Kanungo
That's right.
sharing his thoughts on healthcare.
That absolutely, yeah. Well, my brother's a doctor, so he's actually Dr. Kanungo. I was the dumber of the two children. Let me start with this. As an East Indian male living in Canada, the epitome of life for all Indians is to be a doctor. That is the epitome. I mean, I don't know if it happens in Asian communities as well, but in the South Asian community, to be a doctor is the epitome of success.
Okay.
You could be a billionaire. You could be Mother Teresa. You could be Barack Obama. It pales in comparison to being a doctor. As a child or growing up, I always heard about the importance of being a doctor, and then there's a lot of doctors in our community because of this parental pressure. And the reason why I'm bringing this up is because I have an inherent bias against the whole healthcare debate or the healthcare conversation.
Okay.
So I want to keep that. I want you to know that is. So I might be a little bit pessimistic
About healthcare.
Yeah, and it's rooted in it's a deep psychological pessimistic view, by the way.
Okay. Why didn't you want to become a doctor?
Well, I never had the IQ to
I don't think you need IQ.
I think there is a level, you know what? I don't think you need IQ for many things. I think
Management consulting?
management consulting, you definitely don't need an IQ for it. We can talk about that later. But in healthcare, I mean, to do the test and to get by after each kind of round of, high school, university, then med school, and then you got to be able to pass tests and you have to be intelligent to make it happen. I wasn't blessed in that category. And also I didn't really like blood. Okay. So these two things combined, and I'm not interested in it. Maybe those are the three things.
Okay.
That didn't contribute to my healthcare career or being a doctor or nurse or whatever. You got to be smart to do these kind of things. I'm not blessed in that.
Okay.
But here's my take on healthcare. There's tons of opportunities in healthcare. There are billion, trillion dollar opportunities in healthcare, but we've done nothing.
Mm-hmm.
When as a patient, as I step into a hospital, as I step into a clinic, it's the same experience that I've been getting for the last 10, 15, 20 years, the same experience. I'm sure in terms of research and from an academic standpoint, there's been tons of development. I mean, they've cured tons of different diseases and cancers and whatnot, not cancers, but you know what I mean? They've done a tremendous amount of things. I mean, life expectancy has grown. I think the average, life expectancy, hundreds of years ago was, you die at 40 years old, right?
Mm-hmm.
But now you can live till you're 100. So amazing achievements. But from a patient's perspective, nothing has happened. And I'm worried. I'm worried because you see all these innovations happening in other industries,
mm-hmm.
and you don't see it in healthcare. Why can't I FaceTime my doctor and get like a prescription while I'm at home and then the drugs be sent to my home? Why not? Why can't I get a doctor on demand and that they can come to my house and then they can see what's happening? Why?
I think you can do those, but it's not everywhere yet. There is telemedicine happening.
There is telemedicine happening, not in Canada. Well, there might be.
No, there is.
There is?
In Canada, yeah. I think there is.
Is this what do you see, telemedicine, or is it like can I FaceTime? Can I video medicine? Can I video chat my doctor?
I don't know exactly what's happening at the edges of healthcare in Canada, but I do know that there is telemedicine happening in some of the rural areas, even specifically in Alberta. There's a nurse on the other side, and they'll do very simple stuff with you.
Right, and they can see me?
They can see you.
Okay,
Yeah.
That's good.
Yeah.
So I know there's tons of opportunities. This whole idea of value-based care. There's talked about 3D printing in healthcare, the surgeries, but I'm just hesitant, or I just don't think that there is that impetus to change. I'm not seeing it. I'm seeing other innovations happening in other industries. I'm not seeing in healthcare. So what did Dr. Green say? Maybe he talked about some of the barriers.
He did.
Because that's what I'm talking about right now. What are the barriers?
That too is a very complex situation.
Yeah.
Medicine has a terrible case of pilotitis. We have all kinds of successful innovations that don't spread very well.
Mm-hmm.
It has to do fundamentally with, again, the wetware. And this is something that disruptive innovators or potential disruptive innovators and people doing technology in healthcare, I think, should heed very carefully. In the course I taught in health management and policy, on the first day, I had to disabuse my students, and they were mostly physicians and nurses. What I was teaching was in a program for health management and policy that was designed to take physicians and nurses and respiratory therapists and physiotherapists and so forth as well, but to take healthcare practitioners and train them for leadership roles, to create medical directors for healthcare systems, to create, directors of nursing, that sort of thing.
Mm-hmm.
So the first thing I had to do on day one was to disabuse them of the notion that healthcare is a system for providing technical services. It's very easy for administrators, for physicians themselves, for nurses, for public health people to think in technocratic terms. And that's wrong. Healthcare is not a system for delivering a technical service. It does deliver a technical service, many of them, but fundamentally, healthcare is a system for meeting human needs. People who don't understand why the healthcare system works the way it does are thinking of the technical services. They're not thinking of the human needs. There are human needs involved both on the patient side and the provider side. People are quite set in their ways.
Mm-hmm.
Change resistance in healthcare is enormous.
Mm-hmm.
The old joke about, the only person who likes change is a baby with a dirty diaper is true nowhere more than in healthcare. Part of that is due to the nature of the work. Physicians, especially frontline physicians like family docs, emerge docs, operate at or near cognitive task saturation most of the time. Change is quite disruptive, just cognitively. The workload is disruptive. A friend and colleague of mine at the University of Wisconsin has been using the NASA Task Load Index and studying the actual cognitive burden of medical practice. And being a family physician in office practice, the cognitive workload it's pretty close to the maximum that the human brain can sustain. If you look at other disciplines that run very high cognitive workloads, air traffic controllers, for example,
right,
they are very carefully protected against interruptions. If you want to spend a long time in prison, just try interrupting an air traffic controller at work. Their environment is arranged to minimize distractions and so forth. Is that true in Emerge? Not so much. Excuse me a moment.
That's good. Yeah.
Anyway,
Yeah.
change resistance is very high because physicians, in order to change, physicians have to disrupt their work routines. Those work routines are what allow them to get through a day working at this level of cognitive task saturation. Well, it's very easy if you're sitting in an office somewhere, like me sitting here amidst all my books and papers on primary care transformation. It's very easy to say, well, all you have to do is change things around to work this way. That's enormously disruptive to do, and people resist it for entirely understandable reasons. Changing healthcare also makes patients extremely anxious. Reorganizing systems of care that worried people are expecting to interface with look at what happens in the United States when you attempt to introduce any kind of improvement in healthcare. It threatens somebody's interests. It makes patients anxious. And it often threatens entrenched financial interests in the U.S. especially, to some extent in Canada as well. We have large numbers of specialists making very large incomes doing things that frankly are amenable to disruptive innovation. Certain diagnostic procedures, for example, they required a physician back when they were first developed, but they've become routinized to the point now where it doesn't take a physician to do them. We should be training technicians to do that. And the odds of being able to do that are very low because that directly threatens someone's paycheck, and the someone's whose paychecks are threatened have considerable political influence. In the U.S., the problem is compounded by the for-profit hospital industry, which is also politically very powerful and does not want its profit centers threatened. So there are all kinds of structural barriers, largely relating to either, to boil it down, greed or fear, that make it really hard to do large-scale systems change. And then the nature of the work itself makes introducing change considerably more challenging. We also just don't even have the infrastructures in place to introduce change. For the airline industry, if the landing procedure for 737s changes, if Boeing issues an update and you have to change the procedure, Delta Airlines stands down 20% of its 737 pilots, puts them through the new training program, runs them through simulators, allows them to gain experience, allows them to have that become their new working routine, then puts them back in the flight line, takes the next 20%, and so forth. What do we do in healthcare when we want family docs or emerge docs or whatever to change how they take care of a certain clinical problem? We just put the information out there and we expect them to somehow incorporate that into their work routines sort of, on the fly, without any cognitive support, without any kind of socio-technical system support for doing so. Well, I'm sorry, but just do it as a shoe commercial. It's not a prescription for healthcare change.
I think the most important barrier is the people involved. It's not just the patients. You have to think about healthcare with the doctors, with the administrators, the nurses, just everyone in the healthcare system.
Right, the whole ecosystem.
There's a whole ecosystem. When you're trying to disrupt something, the whole notion of disruption is changing the game forever in some specific way. And when you change that game, and that game being healthcare, a lot of other things are also impacted by that change. And just for instance, let's say diagnostic technology became ubiquitous. Low cost,
what
really
is
quick.
diagnostic technology becomes ubiquitous for those of us who are not blessed with the IQ that you are?
Yeah, well, I'm not blessed with high IQ, but imagine whenever you are sick and the doctor doesn't know what's wrong with you, they'll run you through blood tests. Blood tests are diagnostic technology. Or they might you through a CT scan or an X-ray or MRI, whatever it is. There's numerous different scans and tests that doctors perform on their patients to get information and understand what's wrong with you.
Right.
Because a certain statistic, maybe your iron count is low in your blood, and that might mean a certain thing paired with other pieces of information that they might receive. So all of that is diagnosing a patient, and all of the technologies involved, I would call them diagnostic technology.
Right.
Now, if diagnostic technology became ubiquitous, low cost, quick, convenient, easy, that might mean, for instance, that a doctor in a hospital is out of a job, or a nurse is out of a job.
Right.
And again, that's a huge impact. And he boiled it down to two basic human instincts: greed and fear.
Go straight south from here till you hit Intermountain Healthcare in Utah. Okay. They do a great job of this stuff. People come from all over North America, including from our own department, down there to visit and observe and learn from them about how they do it.
Mm-hmm.
So why isn't everybody, in the whole Western U.S. Why hasn't it spread like a brush fire? Why isn't everybody doing it?
Yeah.
Well, partly because it threatens the entrenched interests of people who get paid a great deal to do things the way they're doing them now. Partly because of fear on the part of some patients who think that this systematic approach somehow takes away from their choice or makes it hard for them to get what they want. They a certain fraction of the population who think that they need to see, the specialist for every sniffle kind of stuff, and a healthcare system that routes them to the appropriate resources. Well, they want to know why they can't see the respirologist for their runny nose.
Okay.
And they demand that. And if you're Kaiser or whatever, it's pretty easy. Those patients quickly drop out of Kaiser and go to a different go back into the swamp of dysfunction that is healthcare in the U.S., but where they can see the respirologist for their runny nose. So, partly it's fear on the part of patients, and partly it's entrenched financial interests, and partly it's that doing it right is hard. It means change. It means change management. That's not easy. And it gets back to the same thing we talked about with Lean before you started recording. It does, organizing healthcare systems that way changes relationships. It is organization. It requires physicians to give up a lot of autonomy. And it's interesting because there are two kinds of autonomy, personal and professional. We tend to confuse those two in the medical profession. We tend to think that our professional autonomy is infringed when we can't just do things the way we want. That's not true. That's personal autonomy. In a system like Intermountain, professional autonomy is highly respected. Okay, the bean counters at Intermountain do not tell respiratory therapists and respirologists and respiratory ICU nurses how to do ventilator management. They may find a guideline somewhere that they think is really good, but the steps are take it to the front line, take it to the respiratory therapists and the respirologists and the ICU nurses, have them look at it, modify it, give it a try, collect data about it, continue to improve it, refine it, adapt it, and follow the data as we improve, as we shorten our length of ventilator times and improve our weaning rates and reduce our infection rates and so forth. That's professional autonomy. Okay, the organization is not telling people how to practice medicine. They are saying, we're holding you accountable for doing the best you can do to improve outcomes for your patients. But it's the professionals who are defining that and who are doing the improving. Okay? The administrators don't decide the practice guidelines. The professionals do. That's professional autonomy. Well, I want to be open the hours that are convenient to me. I want to see the kind of patients that I want to see. I only want to do one physical per morning, whatever. That's not professional autonomy. That's personal autonomy. That's just doing things the way we like for our own convenience. Well, being part of an organized system that's responsive to patient needs and that pursues the best patient outcomes, it does limit personal autonomy. And some physicians are very reluctant to give that up. Other physicians are much more open to, okay, if we want to get better if we want to get better in healthcare, we have to get better as a team. I have to give up some of my personal autonomy so that the team can work better and we can do better for our patients. So one of the reasons that limits the spread is, frankly, physicians who are resistant to being part of a team and getting organized. The truth is, to get better than we are now requires teamwork. The work harder, be smarter model, we've maxed that out. There's no more in that mine. And if you look at how Intermountain does it, it's teamwork.
Patients are often not as receptive to change as you think they are. Because if you go to a doctor and the doctor has done something a certain way for every single time that you visited the doctor, and then the next time you visit, the doctor says, hey, I'm going to try something new. It's never been done before, but these are the benefits.
Right. People don't want to be the guinea pig.
Yeah. Well, you've done X for these many years. Now you want to do Y, but you haven't tested it yet. Why do you want to test it on me?
Right.
And patients don't like that.
Right. No, I can see that. So
Yeah.
is that the fear part?
Yeah,
the
that's
fear,
the
on,
fear part.
on the patients.
Well, there's
But
fear
then
on the
there's
patient's
fear
part.
on the clinician side.
Yes.
Because they don't want to try new stuff.
Well, it's not that they don't want to try new things, but I think if they try new things or if they change the way that they're doing things, they'll either lose out on money or authority or power or whatever it is as
Right.
well. I think that really boils down to just the people, really.
So when you talk about greed, is the greed also on the doctor's part too? Because they're very well compensated
Yes,
for
they
the
are, yes.
work that they do, and they should be. You know, they're playing
Yes.
God in many respects. So, you know, they should be compensated for doing that, and they're dealing with very stressful situations, more so than we are as business people.
Yeah.
But there is a element of greed there. I mean, if for
Yes.
some doctors, if they see a certain X number of patients, they are able to charge X dollars,
Yes.
X number of dollars. And in those circumstances, the more patients you see, the more money that you get. So having a quick turnover, just like as if you were at like McDonald's and seeing as many people as you can will speed up the process.
Mm-hmm.
That isn't that flawed in some respect?
Absolutely it is. I mean, one of the examples that we talked about when I was doing my research is Walmart is providing low-cost healthcare clinics across a number of, I think they're piloting it right now. They have a number of clinics in the US. It's extremely low cost compared to what it would cost if you went to a regular clinic. I think if you're an employee with a health package or health benefits from Walmart, the cost to visit a clinic is $4, which is probably insanely cheap. And these clinics are run by nurses, they're not run by doctors, and they do limited number of tests and diagnoses and treatment. And I asked him, do low-cost healthcare clinics run by Walmart, would that disrupt the whole healthcare system?
Mixed blessing.
Okay.
Yes, it will improve access in some ways, particularly in areas where access is really tough to come by. Walmart does have some footprint in those areas, particularly rural areas in the United States. So there could be some benefit there. The flip side of that is that those clinics are run by a for-profit company. They're not doing this out of the goodness of their heart. They're doing it based on a very specific business model. They're cherry-picking patients. They are seeing the health problems that can be seen in a setting like that.
Right.
With mid-level practitioners and at low cost. They are doing uncomplicated high blood pressure follow-ups. That's great. People should have that. They're doing colds, bronchitis, urinary tract infections, etc. Unfortunately, what's really driving the bulk of healthcare needs in the U.S. and Canada alike, and across the Western world, is complex multi-disease patients. It's the people with metabolic syndrome. It's the people with diabetes and arthritis and depression on top of that, and so forth. Those patients take a lot of time and a lot of effort, and those are the patients for whom continuity makes a big difference. We know from decades of research that relational continuity, seeing a family physician, the same family physician over a long period of time, results in better healthcare outcomes. Okay. But that's probably not true for like a student health population whose healthcare needs are simple and episodic. Where that really makes a big difference, and this is research that my own team has done and published, as well as many other teams, where it really makes a difference is patients with chronic illnesses that need management. It's the patient with high blood pressure, heart failure, diabetes, asthma, COPD, etc. Clinics like this are not equipped to take care of those patients. In fact, it's outside their business model. That would be very costly for them. They'd lose money on those patients. And clinics like this pose a significant risk of disrupting that continuity of care that we know does improve outcomes. So as I say, clinics of this type can be a very mixed blessing. They may provide some health care to people who wouldn't otherwise get it. They may lead to some people getting their blood pressure followed up who otherwise might let it slide, etc. But their business model is fundamentally built on cherry picking the market in a way that could be detrimental to the patients who are at the most risk for bad outcomes and for whom continuity of care is most essential at preventing bad outcomes. By and large, I am not a fan of any kind of healthcare that's built around a profit-oriented business model. If your primary objective is to deliver value to your shareholders, your primary objective is not to take care of your patients. I am not a fan of for-profit healthcare. I'm not a fan of fee-for-service healthcare.
Oh, okay.
If I had my own way, I think physicians would all be a capitation or salary. I don't think a physician or nurse practitioner or anyone else should have any incentive to provide either too much or too little care to patients, should have any incentive to cherry-pick patients. I think the system should be focused on and built around what do patients need, not what's a profitable business model for Walmart or for a group of physicians for that matter. I am by no means just picking on Walmart here and saying, well, they're evil for-profit company. Healthcare, medicine itself, physicians ourselves, don't exactly have a history of clean hands when it comes to our financial incentives in healthcare. I think that I would prefer to see a system that's built around patient needs.
And I thought his thoughts were really interesting, but I think in summary, as a doctor, your main objective should be to meet the human's needs or meet the patient's needs. The outcome of the patient is the most critical.
Right.
Whereas Walmart, being a for-profit company, might be running these clinics to get people in the doors, and they're doing a limited number of treatments, which is great. But at the same time, they're being run by people who are interested in getting the most value for their shareholders, as opposed to getting the best patient outcome that they can get.
I find it interesting that Walmart is doing that, because are they doing it just to get people in the building and so that they can spend, and maybe they're not making money off of it? Or are they just getting, it's just, Walmart is, I think of Walmart as the store for everything. You can get like your nails done, you can get your grocery done, you can get a toothbrush, and then now you can get your health checkup. So they're just another way of getting people in the door. It's like the one-stop shop. So what you're saying is that they're not incentivized to help patients with their needs. Rather, they're more concerned about getting more patients in the door so that they can buy stuff.
Well, I don't want to be sued by Walmart, so that's not what I'm saying. But what I'm saying is you have to question the motives of a company whose main goal is to get the value for their shareholders. And then these same companies are also running clinics, and the clinic's goal and Walmart's goal is not necessarily the same. Right. Or may not necessarily be the same. But you have to question that.
So what I hear from my friends who are doctors is that, there's this push to become more, to strive for better patient outcomes at the end of the day.
Yes.
So that they become healthier,
yes.
That they become, that they're happier, et cetera, et cetera. But it's hard to put a price on that, on the patient outcomes, because some people could heal better. A lot of it has to do with the patients and what they're doing at home, right?
Yes.
And so putting a dollar figure on those outcomes is arbitrary. Like you might provide the best service in the world for the patient. You might go way over and beyond, and they might still die. Or you might do nothing and they might heal. Maybe even compensating physicians or compensating the healthcare system for outcomes may be flawed. That's the challenge.
Yes.
I don't know if you talked to Dr. Green about this, but
not specifically about that, but we did talk about the fact that there are two types of healthcare systems. And I didn't talk to Dr. Green about this specifically, but there's a fee for service.
Yes.
Which is, I'm going to do this test. It's going to cost this much. I'm going to do this treatment. It's going to cost this much. And the idea behind that is to almost incentivize more tests, more treatments, which may not necessarily improve the patient's outcome. And then there's value-based healthcare,
Yes.
which is again a different. And I don't know very much about it. I'm not the expert, but Dr. Green did share his thoughts around the fact that doctors should be getting paid salaries instead of what they are today,
right.
which is getting paid, I think, a fee or a certain payment for every treatment, every diagnosis that they make. And so moving away from that, moving to a salary-based for doctors, model for doctors.
So that they can spend more time with the patients, so that they can...
And ultimately improve patient outcomes, yes.
Of course, this debate could either
Absolutely,
way.
yeah.
And what are the innovations that he's seeing? I mean, we talked about it. You talked about it briefly, but can you expand on a couple of them?
The first thing that we talked about was just in terms of wearable technologies.
Right.
And I asked him just things like Fitbit, Jawbone, Apple Watches, even your phones track your fitness. These days, there's different apps. Are you seeing patients' health improving through
good question.
these technologies?
Well, by and large, right now, I'd say it's more in the form of promise yet to be realized.
Okay.
Certainly, you can track your physical activity, you can track your eating, you can track all kinds of variables, but it's still kind of in the gee whiz phase. There are a modest number of people using the technology. Mostly the people who need it the least, frankly, are the ones who've taken it up the most. Certainly recreational athletes, people with relatively high physical activities already, they're the ones that you see wearing Fitbits around. They're the ones that you see with iWatches on. Although you can't necessarily see it, they're the ones who have the pedometer app on their iPhone,
Right.
just walking around all day.
Right.
Thus far, I think it has not had a widespread impact on typical family medicine practice. I think the potential for it is quite substantial if we can get people to make the paradigm shift that goes with the technology. If we can establish as a social norm that you want to get 10,000 steps a day, the 10,000 steps program is very successful. It works really well. It's easy to understand and do. You need to have a personal trainer and all that. It's great if you have one, but you don't need a whole lot of infrastructure with it. If we could simply establish as a social norm that that's what people do, then the technology is there to facilitate that and make it very easy to do. As with most such situations, the technology isn't really the issue, it's the wetware.
Let me ask you, do you think having a Jawbone or having a Fitbit will improve your health?
I think absolutely 100%.
It will.
And I think it's been a positive thing for humans, because you are able to track. I have no data to back this up, so I'm just totally. I'm thinking.
Are you not tracking your?
No. So I am.
Okay.
And for me, what I like is that, one, I'm able to track my sleep. I'm able to track how much physical activity I'm doing.
Yeah.
All these different, Fitbit, Jawbone, they gamify the situation, or they gamify the whole thing so that you can compete against your friends on your steps and, encourage you to do more. So that has to be good. You're not only creating competition with your friends, but you're also kind of losing weight and maybe even sleeping better. I mean, for me, actually, it's been a blessing in terms of an alarm clock. So it buzzes my arm. I don't have to wake up my wife. Anyways, that's all the thing. Yeah. But the advantage of having these things is not just on a micro level for me and me becoming more healthy. It's on a macro level once you start aggregating all the data and understanding when people are waking up, what they're doing, how much calories they're losing, and blah, 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 blah. And so I don't know who is taking a look at all this data, but at some point when you aggregate all this data, you can do something with it, and you can start understanding how to optimize people's behaviors. You can optimize people's, I don't know. There's benefit to it. I don't see any negative aspects to it. Go ahead. What did Dr. Green say?
Agreed. Well, he said that it's a promise yet to be realized. And what he means by that is the people who are active getting Fitbit jawbones, the people who are not active. And I wouldn't say that it's that extreme, but I think people who are already active are getting these things. They're tracking their health.
Right.
But in terms of making them even more physically active, I don't think it does anything. It doesn't help people who need it the most, or what Dr. Green is saying. And there's a lot of potential there, but in terms of getting it to a point where everybody is using it, everybody is tracking their health, everybody is doing exercise or physical activities, there needs to be a paradigm shift in the cultural norm. It has to be okay, I think. And I don't know why he thinks it's not everywhere yet. People don't think about, oh, I need to track my health or I need to get more physically active.
Right.
I asked him this interesting question. I asked him, what is one uncommon thing that everyone can do to improve their health?
What is one uncommon thing?
One uncommon thing.
Uncommon thing that everybody can do.
What do you think he said?
What uncommon thing can people do to improve their health? I don't know. Laugh. Is that uncommon? Uncommon answer, but something.
Yeah. Well, I think that's a good answer.
Okay, so what was it? What was his
He
answer?
said exercise.
It's a pity that it's uncommon and rare, but the most important thing people could do to improve their overall health is just be more physically active.
Exercise.
Yeah.
Okay.
It doesn't even have to be something that people would necessarily frame as exercise, but just be active. Get out and walk. Participate in a sport if you enjoy that. But here in Edmonton, we have this wonderful winter, lovely snow all over the place, great trails. Just grab a pair of cross-country skis and go out for a nice leisurely ski in the park. Pick up bird watching. It requires you to walk around in the park all day, that sort of thing. Just be more active.
That's not a common thing.
What he said.
You asked him.
Yeah.
What is one uncommon thing?
I did. Yes.
Everyone's gonna say diet, exercise, sleep, sex.
But
I don't know.
But
No, I think
Because-
I don't like his answer. Call him up and tell him no, it's a common thing. It's a common thing.
you would think it's a common thing, but I think we're both physically active. We think of
people-
the world in a certain way.
People, no
you
matter
can't compare that to a doctor who
if you-
sees patients.
if
all
you
day.
live, I don't care if you live in the most remote areas of the world.
But are they doing it? Is the other thing.
Sure, are they? But they inherently know that if I move,
But they're
around.
not doing it. I think
they're
that's-
not doing it.
I think
It's not
that's the
common,
thing.
but the understanding is there. The understanding is there.
The understanding is definitely there.
Like
I would never think of exercise as an uncommon thing.
even like a kid, I would think like a child, like okay, well if I move around, this is probably good. You know, I'm
Mhm.
losing calories. Like it's something that people know. Okay, anyway, so
Yeah.
that's a good question though.
Yeah.
That's a good question.
And then we got into surgery in general, and I'm getting fascinated by surgery. I'm fascinated by the different.
Because robots can one day do your surgeries, right? Is that the notion?
Well, I asked him, and I don't think it'll ever get to that point, though.
In the near future, no. I would never bet against it long term. Technology has been evolving so rapidly that I think it would be foolish to make a prediction either way, to be honest. The limiting factor really is the sensing technology. It's not having the robot do the right things. It's guiding the robot to do the right things. Robotic surgery now is not really robotic surgery. It's robot-assisted surgery. The surgeon is doing the looking, the interpreting, the guiding, etc. The robot may be, close this line, but it's the surgeon who perceives what that line is and where it is and why it needs to be closed and so forth. So it's not the hands, it's the eyes that are the issue there. And so far, the sensing technology is not able to even begin to replace a surgeon at this point. It's the eyes and the brain behind them that are the hard part to replace.
At some point, if the sensing technology gets better and AI is always improving. Maybe at some point.
It might.
Yeah.
The thing is, AI has been just around the corner since the 1970s.
Okay. I see what you mean.
There's a running joke that, it's the technology of the future and always will be. So it's a much tougher problem than science fiction writers of the 1950s believed. So I don't know. As I say, I think a prediction either way would be, I think it's optimistic to predict either way. I mean, it could be a breakthrough that makes it happen next year. It could always be that mirage in the distance. I don't know.
Here's my take on surgery.
Okay.
That with virtual reality and augmented reality, that somebody who doesn't have an education in healthcare, like I think we talked about this before in our podcast, but I said that like a kid in India who's done this surgery 1 billion times on virtual reality, I would rather for him to do my surgery than somebody who's theoretically knows what he's doing and has done it maybe a couple times. But I'd rather get the kid to do it because he's done it so many more times.
Okay.
And that's the power of virtual reality. And augmented reality is cool because, if you put on something like glasses or whatnot, you can see what's happening with the surgery. Maybe it'll give you some like blood, I don't know, some signs, and I don't know, help point things out to you.
I think it's interesting that you say that you want the kid or let's say the surgeon to do it if he's practiced a lot of times. But inherent in both of those answers is the human factor. So we talked a lot about robots maybe replacing surgeons one day. And from Dr. Green's perspective, at least at this point, and maybe even in the near future, who knows about the long-term future, but in the near-term future, robots will never replace surgeons.
You know what? I can see that. It's a very...
robot-assisted surgery, yes. But
right, but they never...
Replacement.
I can see that.
Yeah.
You're dealing with very, like... There's a lot of minutia involved.
Yes.
There's a lot of critical thinking involved. I would think. I've never done surgery.
I haven't either.
But it's like hairdressing. That is something that will never be replaced by a robot. And I will stand to this day to say every job will be replaced by a robot except for
hairdressing.
Hairdressing.
Is
like
your
barber.
hair really complicated, Sean?
Well, it's not complicated, but like you don't want like having a scissor near your head or like a razor near your head. You can't trust a robot doing that. There's too much, of course there's human error, somebody has a scissor, they could poke your head or whatever.
Well, what if they I don't know how your barber or hairdresser cuts your hair, but they always pull out some hair, right? And then they cut it.
Yeah.
Why couldn't a robot do that? They wouldn't be touching your scalp at all.
Have you seen my fade, my man? It's a
very, very close fade. No, I know.
This is a work of art, my man.
Absolutely. I know.
This cannot be done by a robot.
But you can't. But to do those sides, you just get a razor, no?
You do get a razor, but
the razor can't.
It's there's style involved. Like it is one thing that can't be replaced by robots. Just like surgeries, because I think there's a lot of details that need to be massaged. I would say like you can't.
Well, the biggest barrier for robots replacing surgeons is not really, I don't think it's the AI. It's not the critical thinking. I think the AI, well, I don't know. It's hard to say because AI hasn't replaced doctors.
What is AI for those?
Artificial intelligence.
Okay.
So, for instance, we talked about Watson.
I can certainly see the day coming when people will look back on this era and say, man, they let people drive their own cars back then. No wonder they had 30,000 people a year killed on the highway in North America. Right? We are already at the stage where in limited areas, decision support tools consistently make more accurate decisions than physicians do. I've published some of that research myself.
Okay.
Oh, yeah. I mean, I give you a stack of papers if you want. One of the barriers to actually implementing those decision support tools is that people tend to prefer coherence over competence. That is, it's a black box that delivers the right answer. I don't care. I don't trust that it's a black box. Right. Whereas an actual thinking person, well, I trust that person. Okay, but I can prove that that the black box has superior calibration and discrimination. I don't care. I don't trust that it's a black box. So you're always going to run into that issue.
Okay.
Where I think you'll get, if you actually look at the Google cars thing, the Google cars do a better job driving in general. There are instances in which it is necessary for a human to step in. Aircraft is already that way. Right? Pilots don't fly planes anymore. Pilots supervise the system that flies the plane. The joke about the cockpit of the future, it'll have 2 seats, one for the pilot, one for the dog. The pilot's job is to feed the dog. The dog's job is to bite the pilot if he tries to touch the controls. Right. What I can see happening, and right now, we have an ongoing problem with physicians who correctly recognize that patients are more complex than an algorithm can really handle. But characteristically, and this is a fundamental feature of human psychology, they think the exceptions are more common than they really are. They think more patients are an exception to the rule than really are, so they underdo the rule. And if you try to get them to do the rule, they start yelling about how bad guidelines are, and it's cookbook medicine, and so on and so forth. Even though the guideline is right more often than they are. Where I can see things going, and where I think it would be beneficial for things to go, frankly, is for physicians to use guidelines, care pathways, etc., have the freedom to diverge from them when the situation calls for it, because it will. Humans are much more complex than driving or flying an airplane, but have to justify it, have to have an actual written justification. Okay, I'm diverging from the guideline here because of this particular context. And, is that a limitation of professional autonomy? Well, it depends on what your conception of your professional autonomy is. Is it doing things the way I want? Or is it using the best tools I can to get my patient the best outcome I can? So I can certainly foresee a generation from now, a situation where well-developed decision support technologies would give the decision 95% of the time. But there's always going to have to be a physician saying, does this make sense in this context? That's what the algorithm can never replace, is does this make sense in this context? The catch is we have to get physicians past the habit of thinking that those exceptions are more common than they really are. And get patients used to the idea as well.
Right.
Watson won Jeopardy, and then it's this artificial intelligence program that IBM developed to beat Jeopardy contestants, and then they turned Watson to healthcare. And now Watson is in healthcare, and I think it's in other industries as well. But right now, artificial intelligence has not replaced a doctor. You can't just input your symptoms into an app and get a diagnosis back.
Well, you can't. It's called Google.
Well, you could. Is it accurate? Maybe.
Yeah. But is a doctor accurate?
Maybe.
Right.
And so we talked about the biggest barrier is sensor technology.
The barrier is sensor technology.
Yeah, because robots can't see everything, they can't detect everything that humans and surgeons can. When you're operating on a patient, you just have to consider all those different factors. You have to have as much information as possible. And robots don't have that information right now.
Right.
They can't possibly understand. Then once they get all that information, then there's, of course, the incredibly difficult task of processing all that information. What does it mean that the patient is bleeding from this area in particular and not from another area, and
right,
etc.?
So in terms of innovations, the one thing that I was interested in was the 3D printing.
Yeah.
What is this all about?
Well, we talked about it specifically with surgeries, and
because you can make the tools?
No, it's so there's an episode of Grey's Anatomy that used 3D printing, which I think probably really helped 3D printing. But what you can do is imagine if you have a tumor in your, let's say, your lungs. You can 3D print, so you can scan the body first. You scan your body, and then you can 3D print the tumor on what you would call your lungs, and then have the surgeon practice over and over again.
That's good.
On that specific part before they operate on you.
That's what I need. I need somebody to practice before they get in me.
Absolutely. But you don't have cancer yet, and knocking on the table, you don't. Ever, but
Yeah, me too.
yeah.
Okay.
So yeah, we talked about that, and then we talked briefly on how 3D printing can help healthcare.
It's beginning to.
Okay.
There are a number of challenges to be solved before it really will be widespread, but there are also a lot of really talented people working on those technologies.
Mm-hmm.
Probably the biggest challenge for 3D printing really is the material science challenge. The technology itself, the ability to print objects and the resolution with which they can be printed is improving very rapidly. The sticking point really is the materials. And that actually my son's a material science engineer, and one of the things he does is teaches 3D printing.
Fantastic.
But that's the holdup, is really being able to work with the materials and get the physical properties that we need out of the finished object.
So I'm just trying to understand, is it the type of material, or it hasn't been engineered yet? Or
Yeah, it's the structural integrity. To do
Okay.
3D printing on something, it has to go through a tiny little nozzle.
Mm-hmm, mm-hmm.
Well, it's pretty hard to make fiber reinforced plastic that way because the
I see.
fiber isn't going through that nozzle.
Yeah.
Much of the structural properties that we need for effective tools, etc., depend on the larger scale microstructure of the materials in ways that are not particularly amenable to being 3D printed.
Mm.
And then, of course, in medicine, the desired objective really is to be able to 3D print biomaterials, many of which won't survive the physical rigors of being 3D printed. So it's a tough engineering challenge.
Mm-hmm, mm-hmm, mm-hmm.
A lot of promise there.
Mhm.
It's a tough engineering challenge.
Have you ever seen cases where they 3D printed prosthetic limbs or anything like that?
Oh, I think that's probably the first place that'll pay off.
Yeah.
But again, it's the structural
Yeah.
it's the structural integrity that really has to be solved. The idea of being able to 3D print a prosthetic that would be a perfect match
Right.
for the patient's stump and therefore the least possible risk of pressure points and breakdown and so forth, that's a terrific idea.
Absolutely. Yeah.
We just have to get there.
Yeah. Okay.
It's an engineering challenge. It'll be solved. I'm confident.
Yeah.
Engineers are very bright and persistent people.
We talked about prosthetic limbs, for instance. That would be a fantastic area. But I think the big problem with 3D printing to even replace limbs right now is it's so difficult to print out, for instance, biomaterials.
Right.
There's just limitations in 3D printing and the materials as well that you just can't 3D print a heart, let's say,
Right.
or a lung. And
Okay, I got you. I got you on that front. Okay, so the one that I was interested in was you guys talked about Theranos.
yes,
Now, I'm interested in this in Theranos because Theranos has been in the news for the last a month or a couple months. They're doing some great reporting on the fact that it's a $1 billion value company.
Yes.
They've been, I think Elizabeth Holmes, the CEO, she started this company when she was 19 years old. They've been in like they've been basically in the lab. Nobody knows what they've done for the last 10 years. And now they're coming out and their tests have been proved to be fake, or they're falsifying their tests. So anyways, I find it interesting.
Mhm.
I mean, they're obviously refuting it. Can you explain to the obvious audience what Theranos actually is? And then what did you guys talk about?
very tough question. Okay, normally when you go to a doctor or a hospital and you have to go through a blood test, you take this syringe, they take this needle, and they draw out, I don't know how much blood it is, and I don't get blood tests very often, but they draw out a lot of blood. It's a very painful, well, it's not a painful process, but it's a lengthy process. You have to, of course, visit the hospital. You have to book some time out in your day. You have to rest for a little while after they draw some blood, because sometimes they do draw out a lot of blood and you don't want to just drive right away because you might faint. Well, Theranos has come up with a process to very quickly, and I think it's painless, draw out a few drops of blood where normally you would get,
Right.
I don't know how much, but a lot more blood, and run several lab tests on just a few drops of blood.
Right.
This is, of course, completely disruptive because you don't necessarily have to visit a hospital to get these tests done. It lowers the barrier to entry in terms of getting it done because a lot of people are afraid of needles, they're afraid of blood. Well, this just gets a few drops of blood. It might not even hurt you, to be honest. So you could potentially run a test every single day without any fear, without any pain. And again, run several lab tests on those drops of blood.
Amazing.
So,
And
yeah.
so what did you guys talk about?
So we talked about, I asked Dr. Green, how would universal, convenient, quick, low-cost diagnostics disrupt healthcare? And would they at all?
They would be a very mixed blessing indeed.
Mixed blessing, okay.
Yes. For certain applications, they would be very helpful. For patients with type 1 diabetes, for example, it'd be terrific to have such close control of your glucose. For most patients, though, TMI.
Really, too much information.
Yes. We already know that intensive glucose monitoring for type 2 diabetes, home glucose monitoring, etc., doesn't help. Because it's not the problem. We also have, with the improvements in imaging technology, a terrible problem with the discovery of incidental on MRIs and CT scans that then set off clinical cascades and ultimately result in patient harm from excessive invasive interventions and investigations for things that aren't an issue. It's very easy for patients, especially people who are worried, they've had a relative or friend die of cancer or something like that, to think that, well, I should get a whole body CT or a whole body MRI just to check, because that's good, right?
Yeah.
More information is better. No, it's not. It's more likely to hurt you than it is to help you. Right. So I don't know that it would be helpful. I think perhaps ultimately down the road, once it had been around for a long time and people understood at sort of an emotional level that obsessing over every little tick in the graph isn't going to help you. It's just going to drive you nuts and lead you to do things that ultimately will hurt you. Once people, generation or two from now, get that settled in, it might be okay. But at least for the first, I would say, 20 to 25 years of such technology, it will be a very close thing indeed whether it hurts more than helps, and my money would be on the hurts part. Except for very special circumstances, type 1 diabetes, etc., things where careful monitoring is really important. Diabetes in pregnancy, that sort of thing. Where you really do need high-resolution information. But for most patients in most circumstances, frankly, I think it would end up being detrimental rather than advantageous. Now, the ability to do blood tests on a tiny little drop of blood, that's a great idea. And I'd love to see that happen. I'd love to have that available in my clinic, not even have patients go to the lab, but if they could just stick their finger in a little machine and 30 seconds later, I get their lab tests.
Right.
Well, that saves the whole, okay, you need these tests, go get them, come back tomorrow and we'll talk about the results. To be able to do all that right away, especially for hard to serve populations where follow-up may not be great.
Right.
You got them here today, let's do stuff. I would love that technology. But to leap from being able to get an answer quickly to get an answer frequently, that's where you run into the incidental problem.
There's people who, and maybe you're this way, but I know I'm this way. I don't think I've visited a doctor as often as I'd like. I don't know what's the case for you, but do you feel that you visit the doctor on a regular basis to get a full body checkup?
So I have not, and I should.
I think everybody should, though.
Yeah, no, I'm actually delaying my physical. As you talk, I'm like, I got to get that physical done.
Yeah.
I have not.
Now, I don't know why, though. I don't know why I'm procrastinating. It's so weird. because I know I should do it, but
It's, you know,
It's
when you
weird.
have important things, you would
there's
consider.
nothing more important than your health, though.
True.
It's
True.
so weird, though.
We take
Anyway,
it for
yeah.
granted.
Yeah.
We do.
Well, anyways, so he went to the two extremes. There are people that you can't get out of the clinic because they're there so often, and then there are people that you just can't get to come to the clinic because they are procrastinating or they don't want to, or they have to have something extremely serious happen to them before they actually come to the clinic.
This is a chronic problem that all of us in family medicine grumble about.
Mm-hmm.
People seem to fall into two groups. Those who are in their office way too much, the worried well, and those we can't get to come into the office when they need to. These would be your crusty old farmer who won't get off the tractor till he's bleeding so badly he can't drive it anymore,
Yes,
right?
yes.
I'm a farm boy. I know farmers, right? You see a farmer sitting in your waiting room, you better go see what he wants right now.
Yeah.
Because he's probably actually
very
having
serious,
his heart
yeah.
attack in your waiting room. So yeah, it always seems like the wrong people are in the office way too much.
Yeah.
But that just has to do with people's health beliefs and their level of worry and so forth. I think there might be some advantage if testing was really easy and quick like that. It might help us get some of the people who don't come in to come in. But really the issue with those folks isn't so much that testing is hard to get. The issue with those folks is they're not coming in because they don't want to know, because they're kind of living in denial in a lot of cases. And the people who are in the office way too much, well, this would just give them something else to be overly worried about.
Right.
And yeah, you'd see people who don't really need to be following their blood tests really closely, wanting to do them every week because they can, to no real benefit.
Yeah.
Yeah. It's not the hardware or software that's the challenge. It's the wetware.
Yeah. Yeah.
What I'd really like is a good disruptive innovation in health behavior and health education. That's a lot harder than
That's very
technology.
difficult, yeah.
These diagnostic technologies would be terrific for specific cases. So for people with diabetes, type 1 diabetes, or other, like maybe a heart condition or something like that, where they need to be constantly monitored and diagnosed and tested and all these things, low cost, convenient diagnostic technology would be great for those people. And then there are people that are paranoid about their health. Oh no, what's this? Or what's this new mole? Or, oh no, my blood sugar is now whatever it is. I need to go see the doctor. And I think for those people, it would be overkill. It's just too much information for them. And so at least in the short term, if these low-cost diagnostic technology would come out, people would be separated into those two ranges.
Right.
Again, there needs to be, I think, a paradigm shift where people are okay with getting regular tests or getting a regular checkup. I don't know why people procrastinate, but again,
You know what? I have no clue. I think it's just a matter of, people take it for granted and they shouldn't. And, people should get checked up and they should get those
On a regular
mammograms
basis,
and they should do all
Yeah.
that kind of stuff. I don't know what it is. So listen, you've talked a lot about your conversation with Dr. Green.
Yeah.
Tell me what his prediction was around the future of healthcare, where it's going. Is he more of a doom and gloom kind of guy, or is he more optimistic about it?
no, I think he's pretty optimistic about the future.
As Yogi Berra once said, predictions are hard, especially about the future. Brilliant man, that Yogi Berra. It certainly will be different. I think I have some ideas about ways it will be different. I am quite certain that something major will happen that I have no way of predicting and no one else does either. I think certain things will stay the same.
Okay.
I think it will be different in the sense that patients will begin to understand that the medical home model, that team-based and systems-based care does deliver better outcomes. I think patients will start to expect physicians to be working in teams. They will expect to see nurses with much more expanded, much more influential roles in outpatient practice. They will expect to come in to see me sometimes or my nurse or my dietitian. They will come in, they will see a team taking care of them. And I think that patients will come to expect that. I think patients will come to expect much more access to information. Patient portals, online access to their own labs. I mean, why can't a patient pull up their own lab results or x-ray report and look at them?
Mm-hmm.
Well, they can in many places. And I think that expectation will and should become universal. Why can't a patient get online and schedule their own appointment? I can book my own airline flight. Why can't I book my own appointment? Well, they should be able to. My patients should be able to just get on and, and schedule a visit with me. So I think those things will move from the province of some of the best examples, the innovative healthcare systems out there, to become mainstream expectations. I think what will not change is the importance of the physician-patient relationship. Ultimately, it is a system of meeting human needs. We will be able to routinize, automate, and replace with technology a number of the things that doctors do now, maybe even reading x-ray images and that sort of thing. If the machine vision thing ever really gets going, whatever. What we will never replace is the relationship.
So you don't think that at some point, like there's this technology called Watson that IBM develops, which won Jeopardy. They now transitioned into moving it into cataloging and analyzing all the health information and trying to make it a diagnostic machine. There's maybe you'll come up onto your computer and open up something like email, like something similar to email, open up an app, and you'll have a doctor and you'll say, here are my...
I can certainly see patients using online AIs like that for ideas. I see physicians using it too.
But it will never replace.
It will never. At some point, the patient is going to want to come in and sit down and talk to the doctor. That human contact will never be replaced. See, in organizational science, there's a famous saying: we can build a car, a computer, whatever, that's 10,000 times as powerful in 1,000th of the time that we could 20 years ago. Despite the fact that it's been 400 years since he wrote it, it still takes 4 musicians 5 minutes to play a Mozart string quartet. It's never going to get shorter, and you're never going to do it with fewer of them. If you want live music, it still takes 4 musicians 5 minutes to play a Mozart string quartet. There is no such thing as economy of scale.
Right.
That's the part of healthcare that won't change. No matter how good diagnostic software becomes, no matter how good the technical service becomes, that system of meeting human needs that need to be heard, to be understood, to be thought about at an individual level, that will never be replaced. Nor will even the best diagnostic algorithms, Watson, etc., ever completely replace a human diagnostician. And the reason has to do with complexity theory. Humans are too variable. Humans aren't widgets. Context matters. Presentation matters. What you're dealing with when you're dealing with primary care practice is a complex nonlinear system. It is not fully predictable. It is not reducible to an algorithm. It's not just that our technology is not good enough to do it. It cannot be done. And another one of my hobbies, my undergrad is mathematical statistics. Another one of my hobbies is math. I could give you a pretty extensive discussion of complexity theory, but the bottom line is, for the same reasons that long-term weather forecasting is not possible, the same reasons in complexity science that make long-term weather forecasting impossible make replacement of a human diagnostician with algorithms impossible. Assistance, yes, absolutely.
Assistance, yeah.
And no meteorologist worth his or her salt would do without their supercomputer. They run those models and they use them a lot. But they also know that what they're dealing with is a system that is intrinsically not fully predictable. And the further out you get, the greater the potential for sensitive dependence on initial conditions, and for not just linear divergence from what you expect, but catastrophic divergence from what you expect.
Sounds like chaos theory.
It is chaos theory. Chaos is the extreme end of complexity theory. Right. Where we try to stay out of chaos per se in healthcare, but where we live is in complexity, the boundary between linear systems, linear behavior, and chaos. And, it's that fact makes it impossible to ever replace human physicians with algorithms, just as it's impossible to replace human meteorologists with supercomputers. Not that I wouldn't love to have a Watson helping me out, but it's always going to be helping them out.
They want the process to be more transparent.
Yes.
They want real time data.
Yeah. And so in general, that's what he thinks patients will want in the future. He said it himself that it was extremely difficult to predict what will happen in healthcare. Maybe something is just around the corner that will completely disrupt, but I don't think he knows what it is.
Let me give you a crystal ball. In the next 10 years, where will healthcare be, and how will it be different from today? Wang, you're on the spot. Cue the music.
I think patients will be able to not visit clinics. I think they'll be able to FaceTime with their doctors. I think this is already happening as well, but more of it will happen in the future. Have a better relationship with your doctor. Maybe your doctor's on WhatsApp and you can just text him and say, hey, I got a cough and it lasted for X number of days, and he'll ask you a few questions and how long, do you have any phlegm, do you have whatever, and maybe you'll have a quick diagnosis right then and there, or he'll say, hey, I've got a spot open, 10 minutes Saturday, can you make it? And I just need to quickly come and see you and I'll give you some meds. And I think it'll just be easier to access healthcare in the future.
Easier.
Yeah. Because right now you have to make an appointment, you have to call in. I don't like talking to people, as you know, and I don't want to call in. I don't want to schedule appointments, but sometimes you just have to.
Right.
I want to be able to just do it online, just like booking a flight. I can see what's available. Maybe I can see the price, just greater transparency. I don't think, and we talked about this with Dr. Green, I don't think AI will ever replace, something like Watson will ever replace a doctor. There will always be a need for a doctor and just that human interaction, which I thought was interesting because we talked a lot about malls, and I said that malls would just be robots at some point. We'll just you'll ship something or you'll buy something online and you'll just pick it up at the store. You won't need to see any salespeople.
And what did you say?
In medicine, no, I mean, we didn't talk about that.
You didn't talk about that.
But in medicine, the doctor will always be there, he thinks. There will always be a need for human interaction, which maybe might convince me that we do need people like that in malls and stuff. I don't know.
So I think I'm a little bit more pessimistic on this front. I think I'm probably more optimistic on other industries. This one, I'm a little bit more pessimistic. Like, we all know what the innovations are.
Yeah.
It's not a secret to healthcare practitioners, not a secret to us. Like, we know that, telemedicine, drone-delivered vaccines, value-based care, outcome-based payments, healthcare robotics, 3D printing. Like, we've talked about some crazy stuff. None of this will come to fruition in the next 10 years. And I'll tell you why. The health industry is the most complex industry. It's probably the most complex industry other than music, which sounds weird, but music is like hella complicated. is the most complex industry to change because you have to change the entire ecosystem. The primary healthcare clinics, the patients, the doctors, the hospitals, the blah 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 blah. There's so many layers to change that in the next 10 years we're not going to see a lot. I think where we will see the innovation happening is on the consumer side. So things like 23andMe, where they are
mapping out your DNA.
They're mapping out your DNA, and there's a third party that is doing that. I think with Apple Watch, and I think we're just seeing the start of wearable technology and taking your data and aggregating your data and doing things with it. I think that's going to be huge. But the people who are doing that are not the people who are part of the health ecosystem. There are people outside. They're the private practitioners that are doing things. And that's where you're going to see the innovation and some really cool things happening. And they're going to be the ones pushing on the whole health ecosystem to change. And I think and there might be a backlash. You're like, well, you know what? 23andMe and Apple, they're doing a lot better job in monitoring and making sure that I'm healthy than you are the healthcare system. So you know what? I'm going to actually move my whole health future on Apple or Google or 23andMe or Theranos if they're actually real. So I think that is where the innovation is going to come. And I'm very pessimistic about the whole healthcare industry. And I also think that doctors don't want to change too because they're getting paid the work that they're doing right now. They don't want to change things. Mm-hmm. They're very smart people. And if you get a whole bunch of doctors in a room, they're
reluctant to,
they don't want to change things. They're very smart people. Have you ever had a conversation with a whole bunch of doctors? They always think that they're right. Imagine being a consultant or like whatever, coming into a situation with all these smart, very educated, very intelligent people and saying, by the way, you're doing things wrong. They'll be like, hell no, I'm not doing things wrong. It's very hard. It's very hard.
Well, I think change in general is hard.
Change is hard, but
is it not?
It is hard.
Yeah. Change in general is hard.
It's hard.
There's a lot of, and I don't think it's just, there are good doctors out there. It's not just about the money or anything like that, or the power or the authority. But a lot of it is, and this is an interesting point that Dr. Green made, was there's a personal autonomy and there's a professional autonomy. And the professional autonomy is what hospitals are trying to do these days is they're not saying to a doctor, hey, this is a new way of helping a patient. You need to do this. And they give you a manual. They give the doctors a manual and they say, hey, follow this.
Right.
And that's not the best way, of course, to implement change within the healthcare system. One of the things that doctors are trying to do to implement change is they give this book of guidelines. Here's some things that we suggest you do. Try it out, test it, see if patient outcomes improve, follow the data, improve some more, tweak some more. And then if it works, this is now the system to do. That professional autonomy is extremely important to a doctor, but they often confuse it with personal autonomy. And when I say personal autonomy, what I mean by personal autonomy is doctors want to be able to see patients whenever they want. They want to be able to say, I only want to see 5 patients today. That's personal autonomy. That's very different from professional autonomy. And I think the change happens when you try to change personal or professional autonomy in that sense.
Right.
And they're very reluctant to change because they have a way of doing things. They're very smart people. It's very, what's the syndrome? I think it's called ivory tower syndrome. You have these people from up top who don't really understand healthcare and they're saying, hey, this is a new innovative technology. This is the way that you should go. Well, has it been tested? Has any doctors in my hospital been using it? Does it work? We don't know all those things. So you get a lot of that as well, where people they're not in the system and they're trying to change, which is, I think, why it's so difficult for, let's say, a consultant to come in, because consultant's not a doctor. They don't know.
Right.
They haven't been on the ground. They haven't been working. How can they suggest or even say that this is better without working in the field and doing it? So.
Well, Wang, this has been an enthralling episode. I think we touched on a whole number of different topics. Wow. We've done it. So listen, what can people do to support us at the Dip going forward? What do you think?
I think they need to, if they haven't already, please subscribe to the Dip on iTunes, Android, favorite podcast app. Please rate and review the episode. Tell us what you like. Tell us what you don't like. And tweet us if you have any questions, comments, ideas for the next episode. Let us know. I'm on Twitter at Wang Yip.
And I'm Sean Kanungo at Sean Kanungo.
And yeah, I think that's it.
Change is inevitable. The healthcare system is transforming. It has to transform. Get out there and help it transform. Remember what it's like to be a sled dog. If you're not the lead dog, the view never improves.